Good evening, everyone, and welcome to the 5th edition of the session of Best of Grand Round. At Watany Eye Hospital, we have a monthly meeting, as we call the Grand Round, usually on the third Thursday morning. Obviously, at the Corona time, it's a virtual meeting in the evening. So we have about 4 or 5 cases every month. So we collect about 50 cases at the end of the year, and we have an internal jury to choose the best 10 to 12 cases. Those would be the finalists in the annual meeting. In the session we call the Best of Grand Round. Today we have 11 candidates contesting for the first 3 places. They are already winners. They are the best 11 presentations during the year. They will present their cases and they will be assessed by our judges. And our judges today is Dr. Lukan Mishev from Bulgaria, and we welcome him for the first time in the Watany meeting. And we have 2 very dear friends, Professor Dr. Ala Zawawi, our dear friend and the professor of ophthalmology at Alexandria University, and my dear friend, Professor Dr. Hani Hamza, Professor of Ophthalmology at the Cairo University. Dr. Lukan Mishev will hear few words from his friend, our colleague, Dr. Ashraf Armiya, to know who Lukan is. Dr. Ashraf.
Thank you, Dr. Fathi. Dr. Lukan, beside his my dear friend, he is a pole-to-pole surgeon. He is a pioneer in the 3D virtual reality digital visualization and surgery. He is the head of the Focus Eye Clinic, Sofia, Bulgaria, and he's a pioneer in the live streaming of ophthalmology. He's the first human cataract surgeon with a virtual reality device. He innovated the suprachoroidal needle, the Mishev Shopper. He took the award by the ARVO by the varicella zoster in the pathology of the CSR hypothesis. Thank you, Dr. Lukan, for being with us.
Thank you, Dr. Ashraf. Thank you.
Thank you, Ashraf, and welcome, Dr. Mishev. And we'll be starting our presentations now. And just a quick word to our presenters that the time allowed is 6 minutes. And one of the items for scores is the presentation skills. So you should know that if you exceed time, I'm sure the judges will count that against you. So we hope everybody will be committed to time. After you finish your 6-minute presentation, the judges will ask you 1 or 2 questions in 3 minutes. This will help them in the final score. And I think we are ready to go ahead with the first presentation. Dr. Peter Sameh, if you'd like to go ahead.
Okay. Okay, my voice is clear. Okay, good evening, dear colleagues and professors. Much honored to be here. For all of us, while managing any case, we are aiming at reaching our main goal, which is a well-functioning eye. But for the patient, cosmesis also comes in priorities. So by doing both, making the eye reaching patient satisfaction, and that what was done with this case. A case of 4-year-old female child came to outpatient clinic complaining of left eye deviation and fine eye movement since birth. Her mother only gave history of the same condition happened to her, the mother herself, and the grandfather. On examination, visual acuity, patient can fix and follow OU, anterior segment examination, total NIRIDIA OU. As you all know, NIRIDIA is associated with cataract from 50 to 80%, and this patient had a left posterior polar cataract with nystagmus in both eyes and left XT. Decision was taken firstly for left eye phacosurgery. Phaco was done with posterior rhexis. Anterior vitrectomy, thickness toric single piece was implanted in the bag. In follow-ups, all was well and arranged to remove sutures after 4 months. 4 months later, sutures removed. Patient reflection was in the hypermetropic side as it was expected. Did we miss something? Yes, for sure. Here comes the turn of managing aniridia. In all times, it was managed non-surgically by photochromic lenses and wide-brimmed hats just to decrease eye exposure to sunlight. On 2018, FDA approved iris prosthesis for adults and children. But the question comes on top, can we use sulcus iris implant? As you all know, aniridia is associated with glaucoma. So putting iris in the sulcus, iris implant in the sulcus will increase the risk. So can we use it endocapsular? Yes, but in our case, this can be done. We did posterior rhexis as mentioned before. So putting implant endocapsular will increase risk of the whole capsular rupture. So managing aniridia here must be at the corneal levels with technique of keratopigmentation, which dates to 2000 years back. There is superficial pigmentation, but here we used intralamellar pigmentation technique and a pricing effective functional and cosmetic one though. It's called FAC, femtosecond laser assisted keratopigmentation. We got the same idea of intracorneal ring segments. A tunnel is done by femtosecond laser in the corneal stroma, like the tunnel done for rings, but this tunnel is taking shape of iris. And afterwards, a bioinert pigment is injected in this tunnel. We used the same software program used in ICRS with some modifications. As shown, the parameters of a normal ICRS case done in our hospital, look at the outer and the inner diameter. And here is our case. We increased outer diameter from 5.9 to 9 millimeter and decreased inner from 4.8 to 3.8 millimeter at depth of 300 microns, which next time will be modified to be more superficial for stain color to be more evident. And finally, we did incision at 90 degrees. Here is the video. Sorry. Okay, again.
Don't worry, I will stop the counter. Don't worry.
Okay, again. Okay, here we go. It's the tunnel done with a femtosecond laser.
We cannot see the presentation.
Can't see presentation. Sorry for the technical problem. We are working on it.
That looks better.
Okay. That tunnel done with a femtosecond laser, same as rings. Okay, that's the incision at 90 degrees. A blunt dissection opening the tunnel. A new wound for better access to the whole tunnel. Also blunt dissection. It's all dissected. The tunnel is now open. Here is stitches closing the wound, but getting deeper in stroma, not edge to edge, to prevent dye leak. It must be deep. And here is the injection of the bioinert pigment or dye. That's okay. And that's how it looks like after 1 month after removal of stitches. Possible complications of FAC: intraoperative perforation, infection, dye leak to the anterior chamber, postoperative fading of pigments, photosensitivity, corneal edema, field defects, alteration of eye contour in MRI as shown in this picture. In literature, study dates back to 2012, a trial of double tunnel femtosecond laser keratopigmentation two tunnels, a deep one for dark pigments absorbing excessive sunlight, and superficial one for the other color. Same like iris, but we don't know how the case on the long term looks like. And that's the final one. It's important and the most recent study published at July 2020. This study following up patients after keratopigmentation using femtosecond laser, including 79 eyes of 40 patients, following them from 6 to 69 months at a mean around 29 months. Results showed all are satisfied with adequate management of any complication. Take-home message: combining bioinjection and femtosecond laser techniques helped us to reach both function and cosmesis. Using and modifying software of femtosecond laser program used in ICRS in managing aniridia is a very good example of innovation which always a surgeon must have. Thank you.
Thank you, Peter. And now the time for the judges to ask you one or two questions.
I have one question for Peter. Why didn't you make two radial incisions so that you can access the inferior tunnel better?
Yes, I think next time we will do this. We needed another incision. We did it with the blade intraoperative. I think next time we will do it one at 90 and one incision at 45 with the femtosecond laser.
What are the types of dyes that can be used for this technique? And are there different colors that we use, or is it all black?
Yes, there is multiple types of dyes. There is organic and non-organic. The non-organic metallic, but those advantage of the organic types are that they have many colors. Okay. And second advantage is it fades less than the metallic. The metallic one, the gold, which is always black, but in the organic dyes, which we use like China ink and Indian ink, there is varieties of color can be used now. It's present in the market right now.
Thank you, Peter. I think we'll have to carry on with the second presentation.
Can I ask one important question here, please?
Please go ahead.
Have you ruled out Gillespie syndrome or Wager syndrome, since this is congenital aniridia, and how you feel the keratopathy, which normally evolves as a vascular membrane from conjunctiva over the cornea, will affect your approach?
Yes, I think we chose this technique as it is a seeing eye. There is a potential of vision in this eye. She can fix and follow. The field and the axis, visual axis is clear. So we used this technique so we can do same like iris. We are not doing only tattooing for cosmesis or photosensitivity. We are doing it for function, so the patient can see. This patient, I think we chose this technique as she can see later. She will see. She must have this intervention, not corneal tattooing for the whole cornea.
Okay.
Thank you.
I think we need to go ahead. Dr. Therese. Therese, can you present the second talk?
Our next presentation is eccentric posterior polar cataract to be presented by Dr. Hajar Sharawi. Please go ahead, Dr. Hajar.
May I ask always the presenter should be ready by the time the judges are asking questions to the previous presenter. Please get your material ready. Please go ahead.
Assalamu alaikum, everyone. My name is Hagar. I'm going to present a case titled Eccentric Posterior Polar Cataract. 4-year-old female patient presented with right esotropia noticed 8 months earlier. Her history was irrelevant except for positive consanguinity. Examination only revealed right posterior polar cataract and esotropia, and the patient was not cooperative for fundus examination. Ocular investigations were ordered. For both eyes, flash BEP and ARG showed only mild dysfunction. Right ocular ultrasound suggested posterior lenticonus. Regarding the retina, it showed juxtapapillary tractional retinal detachment attached to a membrane which extends to posterior vitreous trace, as shown here by the green arrow. The patient was immediately referred to vitreoretinal specialist for second opinion. He suspected persistent fetal vasculature, but by examination under anesthesia, he only noticed nasal retinal elevation without significant traction with healthy macula and disc, and he recommended to proceed with lensectomy as a chance. What possibly caused unilateral posterior polar cataract here is posterior lenticonus, which was suggested by ultrasound, and what caused localized tractional retinal detachment here, most probably a mild form of posterior persistent fetal vasculature. Preoperative photo taken at OR theater. You can notice the opacity a little eccentric, which is a little bit unusual. Our management plan is first to eliminate the opacity impairing normal visual developments. About timing, she's in a critical age with visually significant opacity. Our goal to remove the pathology and ensure clear visual access. Techniques will be discussed later. Second, to correct significant refractive error. Common practice here is to implant beyond the age of 2, which was safe for our patient. Third and last step, force use of amblyopic eye by whatever technique gives us the best compliance. Quickly reviewing possible surgical approaches for our patient. To go for lensectomy and leave the patient aphakic for secondary implantation later, only valid for infants and younger children. As I said before, the better alternative here is to go for lensectomy with primary IOL implantation. Again, to leave the posterior capsule intact, you needed to be clear in the first place, which was not available here. So the better choice is to go for primary posterior capsulotomy, again with or without anterior vitrectomy. Common practice is to do to preserve anterior vitreous beyond the age of 5. Again, you have the choice to do this either before IOL implantation utilizing limbal approach, or after implantation utilizing pars plana approach, which is commonly. Choices of IOL placement for best outcome in the bag. If you have a problem with capsular remnants, go for sulcus fixation and the better alternative optic capture technique. Either utilizing anterior capsule rim or posterior capsule rim, or both, called capsular membrane. Bag and lens technique utilizes both openings with special lens morture IOL. Our surgical plan was to go for lensectomy, primary posterior capsulotomy, anterior vitrectomy, utilizing limbal approach before in the bag implantation. Starting the video here. Starting with manual anterior rhexis. Notice frequent regrasping. Highly elastic capsule. Completed successfully. Now partial hydrodissection. Irrigation aspiration of very soft nucleus, but very adherent posterior plaque. At this point, the surgeon has been changed, as you cannot proceed through limbal approach without at least jeopardizing the continuity of anterior capsule rim. The surgeon decided to go for pars plana posterior vitreorexis and anterior vitrectomy after IOL implantation. Starting with implantation, the leading haptic already in the sulcus. Optic entirely rotated into the bag, leaving the trailing haptic in the sulcus. We end up with ovaling of anterior capsule rim, indicating successful optic capture. Moving to the last step, starting with removing the opacity, then gradually enlarging the opening. Very controlled. Endpoint here is to leave the opening smaller than the optic diameter by around 1.5 millimeter. After proper anterior vitrectomy, closing the wounds, steroids injection, and we're done here. Back to our management plan, we already eliminated the opacity and corrected the refractive error by implanting a 3-piece IOL anteriorly optic captured. For amblyopia management, parents were instructed to start partial occlusion therapy immediately postoperatively. Last photo taken a month later. Reviewing literature about pars plana approach for posterior capsulotomy and anterior vitrectomy after IOL implantation provides better access to posterior capsule with better control over opening size and safer anterior capsule, allows for broader anterior vitrectomy with less risk of vitreous herniation to anterior segments. Study showed comparable results to limbal approach in post-operative visual acuity with higher incidence of intraoperative complications, especially iris-related with limbal approach. Another study showed less incidence of post-operative complications with lower rates of reoperation than limbal approach. Unfortunately, it needs skilled hands and may cause intraoperative retinal tear, and detachment could be missed easily. Benefits added with optic capture technique gives us better IOL fixation and centration with less incidence of visual axis opacification development. Take-home messages. Surgery in pediatric cataract is only the beginning of prolonged course of treatment. Pars plana approach in pediatric cataract surgery is a safe and reliable alternative. Long life follow-up for secondary glaucoma following pediatric cataract surgery is crucial. Thank you.
Thank you, Hajar, and thank you for committing to time. And it's now we have 3 minutes for questions with the judges. And please, Lydia, get your presentation ready.
Hajar, can I ask you a question, please?
Of course.
You have chosen to do hydrodissection rather than hydrodelineation in such posterior polar cataract. Was it the right decision?
Okay. I couldn't.
You know
sorry,
that your case is posterior lenticonus and you have an opacity near the posterior capsule.
Yes.
And yani, any doubt about the integrity of this posterior capsule? If you
already
have to choose between both
the ultrasound already proved that the posterior capsule was intact, and we didn't do a total hydrodissection. We only did partial hydrodissection. We didn't reach the opacity, site of opacity itself. Of course, hydrodelineation would be a better choice here, but in a good hands, I think Yani it could be handled with partial hydrodissection.
Any management for the nasal RD that you have said that discovered before the surgery?
For me, it's just follow up.
Thank you.
Thank you, Doctor.
Hajar, one last question. Can I ask you another question? I mean, this is an abortive form of persistent hyperplastic primary vitreous or persistent fetal vasculature, as we say. In your opinion, what is the advantage of the pars plana approach in this case relevant to the retinal condition?
I guess, in my opinion, it relieves any possible traction over the retina, which is achieved better with pars plana approach.
Yes, you're right, because if there is a connection between the nasal retina and this anterior part, with growth of the eye, it can lead to a retinal tear and detachment in future life. So this was a good approach that you have chosen.
Thank you.
Thank you. And now we are waiting for the scores of Hajar, and we are now ready now with the third presentation with Dr. Lydia Magid. Please go ahead.
Good evening, everyone. Back right.
Press F5.
23-year-old young man surgery and refusing to wear glasses. But his refraction was found to be plus 15 in each eye. So what would you do for this case? Would you go for corneal refractive surgery? On pentacam, you could see that his cornea is quite thin for refractive error so high. His UBM shows that there is iridolenticular contact and a narrow angle, so you wouldn't choose phakic IOL for him either. Looking at his biometry, his axial length is 16 millimeters in each eye. And using the Haig's formula, his required IOL power for emetropia would be 50 diopters in each eye. So this case was selected for clear lens extraction with implantation of 2 IOLs, also known as piggyback IOL implantation. The anticipated difficulties were IOP elevation with local anesthesia, a sunken crowded eye with risk to the cornea endothelium, a shallow AC, narrow angle, and iris chafing, and chronic uveitis. And also, worst of all, would be choroidal hemorrhage or detachment. So in anticipation of these difficulties, he was given a pre-op mannitol IV drip, hypotensive general anesthesia, and surgical technique as follows. An anterior clear corneal incision within a long 2 millimeter tunnel was constructed, followed by injection of a heavy visco. We don't allow the eye to empty as far as possible with minimal entry and exit into the eye. The cataract is treated as a hard cataract with elevation of the bottle, a high IOP setting, and slow, delicate movements in the eye. And then the incision is widened for implantation of the IOLs. First of all, the SA IOL was chosen to be implanted into the bag. The power chosen was plus 37 in this first eye, the right eye, to implant the highest possible power within the bag in the anatomical location, leaving only a residual very thin lens to be implanted in the sulcus. The SA was chosen because there are very high powers available in this model and it is easy to unfold with minimal manipulation. Now the Sensar 3-piece IOL, in this case a plus 13 diopter IOL, is being implanted into the sulcus with delicate dialing to ensure that the IOL is well placed with the haptics anterior to the anterior capsule and posterior to the iris, and that the optic is well centered. A corneal suture is prudent at this stage to prevent AC fluctuation. And then visco is meticulously aspirated from the AC, the bag, and from in between the 2 IOLs. This prevents an unnecessary IOP spike and also prevents the complication of interlenticular opacification, which is an opacified layer that occurs between the IOLs, similar to PCO. Then a miotic is injected to constrict the pupil and form a peripheral iridectomy using a vitrector. The miotic ensures that the iridectomy is most peripheral, and the vitrector prevents the complication of iris prolapse related to surgical iridectomy, attempted surgical iridectomy. Then the wounds are hydrated. And this is his first day post-operative image showing a round regular pupil, a patent peripheral iridectomy, a quiet eye, and the corneal suture in place. His spherical equivalent is plus 3 and expected to improve on removal of the corneal suture. This is another image showing the reflections of the 2 IOLs with the deep AC and clear cornea. And this is a video of the IOL implantations in his other eye. Again, the plus 37 SA IOL in the bag, followed by injection of visco and implantation of the sulcus Senstar 3-piece plus 12 diopter IOL. Again, dialing is done slowly and carefully to make sure that the haptics are in the correct location and that the optic is centered. And this is his first day post-operative image showing the reflections of the 2 IOLs, the round pupil, and the patent PI. Again, his spherical equivalent is plus 4 and expected to improve on removal of the suture. The literature states that piggyback IOL implantation is a safe and valid solution for nanophthalmic eyes, and that bag sulcus implantation is preferred to bag implantation because it reduces the risk of interlenticular opacification and leads to a 0.5 diopter myopic shift, which is required in such a hyperopic eye. Take-home message is that piggyback IO implantation is a useful solution for non-ophthalmic hyperopic patients with careful patient selection, preoperative prep, and meticulous surgical technique with close follow-up. Thank you.
Thank you, Lydia. And now please stay for answering one or two questions from the judges. And please, Mona, get your presentation ready.
I have one question. Why you chosen to implant sensor instead of MA60 Alcon lens? That way you will have similar materials with similar refractive indexes. We know that sensor material is different than the Alcon material.
I actually don't know.
Okay, thank you.
Can I ask a few questions, Dr. Fathi, please?
Go ahead, please.
Lydia, you haven't told from the start how you categorize these short eyes. You have said that the anteroposterior diameter is 16. What's about the anterior chamber depth? And you have 3 categories actually. And what is your case? Fit into which category? Because the management of each category is different from each other. If the anterior chamber is shallow or normal, this is one item, and the anteroposterior diameter. You have to tell us what's the anterior chamber depth in your cases. Not every nano case has a shallow anterior chamber actually, and have the experience that Rexis is usually easy in such cases, not as told beforehand. Also, what is your result? You have told that you have put 37 and 12. What do you expect? Because Haigis told you that you have to put 50. What is your outcome? You haven't shown us your the refractive outcome of such a case.
Actually, I did show that his refractive outcome turned out to be +3 spherical equivalent in his right eye with, should I bring back the slide?
No, just answer the question.
No, just answer. Just answer.
Yeah, it expected, there's an element of astigmatism, a -2, that is expected to improve on removal of the corneal suture.
Expect always a hypermetropic result, and always put over this Haigis lens, Haigis formula by 1 or 2 diopters more. Also, you told us in the as a message that the interlenticular opacification is prevented by actual and thorough removal of viscoelastic between the lenses. Actually not. Actually, it is different materials if you can, like Lucan has told you, and implanting one in the bag and one in the sulcus, this is a little bit can guarantee the prevention of interlenticular phyoplegia, which is a drawback, which is a horrible drawback. You can't do it by YAG or anything else. Thank you very much, Lydia.
Thank you, Lydia. And now we're waiting for the results. And I hope Mona is ready with her presentation. Dr. Trace.
Going to present refractive freedom surgery. Start, Dr. Mona, please.
Good evening, everyone. Our presentation today is about refractive pterygium surgery. Aim of our study is to improve the visual results predictability of pterygium surgeries.
You have to share your screen. We cannot see your presentation.
Okay, just 1 minute, please. Can you see it now, Doctor?
Coming.
Aim of the study is to improve the predictability of visual results of pterygium surgery. This study includes 30 eyes of 30 patients, are divided in 2 groups. Group A, 12 patients had pterygium surgery. Group B, 18 patients. We decided not to do surgery and go with conservative treatment.
Preoperative and postoperative assessment was done by manifest refraction and cylinder with Pentacam. Postoperative follow-up was after 1 month and 3 months. Visual acuity assessment showed that the best corrected visual acuity was ranging from 0.2 to 0.7. The manifest cylinder range was from -0.5 to -9 diopters, and the Pentacam astigmatism was ranging from 2.8 to 23.4 diopters. Now I am going to discuss some cases. We decided to do surgery for them and why we decided to do surgery. Case 1, a 74-year-old male with history of left recurrent red eye. The vision was 0.4. When we ordered him Pentacam, it showed 21.6 diopter induced with the rule astigmatism. This is a slit lamp photo for this patient showing that the fleshy pterygium reaching the visual axis. This is a montage video for the surgery. We remove the pterygium head and we are clearing the cornea using crescent knife and with using diamond burr to remove any remnants. We excite the pterygium. In our protocol for this study, we use conjunctival autografts from the patient and attach them using fibrinogen glue. So our surgery is sutureless. This is a slit lamp photo 2 weeks after surgery. And this is a 1 month photo for this patient after surgery. And the vision now is 0.6. And the postoperative Pentacam is showing 4.5 corneal astigmatism. And I remind you, it was 21.6 diopters. The second case is a 70-year-old female coming with history of right blurring vision. The vision was 0.2. The preoperative Pentacam showed 4.3 diopters corneal astigmatism. And the postoperative Pentacam showed corneal astigmatism of 1 diopter. And the vision in this patient improved to 1. Best corrected visual acuity, it was 0.9 unaided. The third case is a 59-year-old male with left blurred vision and redness. The vision was 0.7. The preoperative Pentacam was 9.3 diopters, corneal astigmatism. Postoperatively, the astigmatism improved to 3.6 diopters. And the vision is still 0.7 and best corrected to 0.9, but the visual quality improved much due to improvement of astigmatism. The second group, we decide not to do surgery. For example, case 1, 30-year-old male with left conjunctival lesion. The vision was 0.6. This is a slit lamp photo for this patient. When we ordered Pentacam for this patient, it showed 3.4 diopter of astigmatism, but there was a corneal thinning and irregular astigmatism, so we advised him not to do surgery. The second case is a 38-year-old male with right red eye. The vision was 0.6. The corneal astigmatism was 3.7 diopters, but it shows against the rule astigmatism, and actually the pterygium was flattening to the against the rule astigmatism. So if we remove the pterygium, the vision will become worse. We advise him not to do surgery. The third case is a 29-year-old male with right disfigurement. Vision was 0.7. The corneal astigmatism was 3.7 diopters, and it showed irregular astigmatism due to corneal scarring. And we advise him not to do surgery as the result unpredictable. This is a graph for the results of our study. The preoperative Pentacam and postoperative showed much improvement. The mean preoperative was 12.6 and postoperative is 2.8 diopters. And the best corrected improved in almost all cases. Take home message. Not all cases of pterygium will benefit from surgery, but cases with flat horizontal meridian will get benefit. Minimal astigmatism on Pentacam or against the rule astigmatism will not get benefit from the surgery. Cases with irregular astigmatism results are unpredictable. They are usually associated with corneal opacity. Thank you.
Thank you, Mana, and thank you for committing to time. And now for you to receive questions from the judges. And I hope Christine Hani will be ready with her presentation.
I have one comment. I completely disagree with using pentacam of evaluation of corneal width pterygium. We know that the tear film can affect the readings, what is left for a pterygium. So all the presentation is based on somewhat unreal assumptions that the pentacam can lead the decision. Pterygium from the visual axis is normal to improve the vision. Thank you.
Yes, I know, but in this presentation, we show that the causes of, there is no, not only, we remove pterygium not only for cosmetic causes, but if we use pentacam, we can improve the visual predictability, but we decide to do this study on this idea, not because eliminating the rule of astigmatism surgery, but just to improve the vision after the predictability of visual acuity after the surgery.
As advice, I can suggest using anterior segment OCT to evaluate the depth of penetration of the pterygium and to decide to do surgery or not.
Okay, thank you so much. Sure, we'll put it in our minds.
Any more questions?
What have you done in the cases that you have decided not to do surgery and they are coming for cosmetic reasons, red eye and ugly looking, and you have preferred just not to do based on the pentacam results? We are faced with such cases. What is your solution then?
Fortunately, we could convince them that the visual results will not be predicted or will be worse, and they are convinced. So they came for follow-ups, and actually we discovered that the pterygium didn't increase more or affect the vision anymore, and they are satisfied.
Thank you.
Thank you.
Thank you, Mana. And now the next presentation is Dr. Christine Hani. It's half lens, but full of hope.
Hello. A 14-month-old boy presented to clinic for second opinion about his right eye. He had a history of trauma with metal object 2 months ago. He was diagnosed with ruptured globe then and primarily repaired elsewhere. His ultrasound showed a normal posterior segment. The boy was examined under anesthesia, and it revealed a sutured corneal wound, anterior synechia at the site of the wound, ruptured anterior capsule, and white cataract. This is another picture showing the wound and the cataract, and surgery was performed in the same session. We started our surgery with synechiolisis, releasing the iris from the site of the wound, and placing iris hooks to dilate the pupil. 4 ports were opened earlier for the hooks, and the lens is now visible. We found a part of the lens is missing, and we don't know exactly what happened, but we think that the zonules in this area ruptured and the back was retracted and fibrosed. Removing the lens matter with irrigation aspiration only, since it's a young child and the lens is soft. As the cortex being removed, something odd was noticed here, a foreign body. Going in to pull it out. And we can see now that it's hair, an eyelash probably. And it might have gotten there with the primary repair or the initial trauma. Proceeding with posterior capsulorhexis, which is highly recommended in young children to ensure visual access stays clear after the surgery. And we will elaborate more on this point further. and then anterior vitrectomy was done. Here we started widening the rexus with the vitrectomy probe. Posterior rexus is usually done smaller in size than the anterior one, but here in this case, the anterior capsule was ruptured with the trauma. Viscoelastic and implanting the IOL. But as we can see here, the IOL went into the vitreous. But with some manipulation, it was able to be retrieved to position, and the optic was pushed and captured in the posterior rexus. And this is how it looked finally. The IOL was centralized. Traumatic pediatric cataract, this is post-operative, and this is 10 days after, 1 month while removing the sutures. Traumatic pediatric cataract is the leading cause of monoocular blindness in children, accounting for around 30 to 60% of all pediatric cataracts. Most children with traumatic cataract are preschool age. Sharp metal is the most common mode of injury. Without effective and prompt treatments, pediatric cataract will lead to amblyopia, strabismus, low vision in life, and even blindness. There is a controversy in whether to implant primarily or wait, favoring implantation, especially in developing countries where contact lenses for correction of aphakia are impractical and post-operative care and follow-up are difficult. And an opinion against, based on the fact that estimation of axial length growth and accurate prediction of IOL power to avoid myopic shift in adulthood is a challenge. PCO is the most frequent post-operative complication. It has been reported in up to 100% of infants after cataract surgery done without posterior capsulotomy. Age is the main factor, and it is inversely proportional to PCO development. YAG laser therapy has limitations, including need for general anesthesia. Still, secondary opaque membranes may be formed on intact vitreous surface. The high incidence of PCO necessitates primary management. Posterior capsulotomy and anterior vitrectomy proved to be successful to maintain a clear visual axis, but IOL dislocation in secondary membranes are some of the disadvantages. Optic capture is a technique to prevent PCO and stabilizing IOL like we did in our case, done by positioning haptics inside the capsule and pushing optic through posterior capsular rexus, resulting in closure of the bag. Techniques is advocated for by many papers, stating that it may help in preventing secondary membrane formations, reduce visual axis opacification, and decentration. Visual rehabilitation is important sequel to surgery, regular follow-up, correction of any residual error, and educating the parents about importance of patching is crucial. We should remember that in 90% of the cases, ocular trauma prevention is possible. Public health campaigns should be developed aiming to educate both caregivers and children about eye injuries and how to prevent them. The area of pediatric IOL implantation is still controversial. Amidst the controversies, one thing is certain, that the visual pathway must be clear after surgery to provide satisfactory visual acuity and decrease amblyopia. Take-home message is that traumatic cataract in a developing eye of a child can be a challenge, like missing half a lens. But every effort has to be done to give the child hope in a better vision and a better chance in life. Thank you.
Thank you, Christine. And please, you'll be receiving a few questions from the judges. And I hope Fadi is getting ready with his presentation.
Christine, in order to tamponade this area that you have discovered that there is no lens and no capsule, what would you have proposed, or what have you done?
We captured the optic in the posterior rexus, and we.
Yes, I mean to start with what are the measures? Would you tamponade with a viscoelastic or?
Viscoelastic was injected with every step, sir, and posterior to the bag and posterior to the lens, and with every step.
With every step. Which type of viscoelastic have you injected?
I think that was methyl. It was
Yes. It's okay. This is good. Thank you, Christine.
Thank you.
Can I ask one question?
Sure,
In
please.
the end of the surgery and the post-op images, I saw irregular pupil. So probably angle scarring was there. How was the IOP of the case?
No, the IOP stayed normal. Yeah.
Thank you.
Thank you, Christine. And now, Dr. Trace, please. Who's next speaker?
Our next speaker is Dr. Fadi Wahid, and he's going to present a clue for one of you.
Good evening. Clue for one of a few. We will start by personal history. She's a 63 years old female patient presented with bilateral simultaneous gradual diminution of vision of 2 months duration. She has hypertension and metastatic breast cancer. She had bilateral cataract extraction surgery 3 years ago. Ophthalmological examination revealed the vision in the right eye was 0.4 and in the left eye was 0.16. Both eyes were previously 0.7. Pupil showed normal reaction with no relative appreciable defect in both eyes. IOP was normal in both eyes. The patient was pseudophakic, and posterior segment showed a dull foveal reflex and macular edema bilateral. So we asked for OCT macula, which showed this lesion, showed the bilateral cystoid macular edema and some retinal schisis. So this is a case of a newly developed cystoid macular edema in previously healthy eyes. Okay, what can we think about? Because we have some differential diagnoses to consider, like posterior uveitis, diabetic maculopathy, retinal vein occlusions, choroidal tumors, post-operative cystoid macular edema, some genetic disorders, and drug-induced cystoid macular edema. Also, the first few causes can be are not for this case, as the patient have quiet eyes, no signs of uveitis, she's not diabetic, no signs of hemorrhages, so we can exclude retinal vein occlusions, no choroidal masses, didn't have any operations recently. So we should think about that it may be drug-induced. Okay, let's have a look on her fluorescein angiography. This is her fluorescein angiography for both eyes, which showed no leakage. So it is a case of a non-leaking cystoid macular edema. Okay, so there are few causes that can lead to cystoid macular edema without macular leakage in fluorescein angiography, like juvenile retinoschisis, some case of atypical retinal pigmentosa, some drugs like tamoxifen, interferon, prostaglandins, epinephrine, timolol, niacin, taxanes. So let's go back to personal history, where we have a clue. This patient has a metastatic breast cancer. This patient had started chemotherapy a few weeks before her eye complaints. She was in paclitaxel, Herceptin, Perjeta, carboplatin. All of them are chemotherapy used for breast cancer. So what to do next? Shall we start intravitreal anti-VEGF injection, stop the offending drug, start any medical treatment? Okay, let's have a look about previous case reports when we have a clue. Okay, as we see, there are few cases with the same complaint and the patient on the same treatment, which is paclitaxel. All the patients have bilateral cystoid macular edema. All of them complained of decreased vision in both eyes. First line of treatment in these cases was stopping the offending drug. Some of them was given medical treatment in the form of topical non-steroidal eye drops and systemic acetazolamide. About half the cases needed anti-VEGF injection. Most of them needed 3 to 6 weeks to completely recover, except only 2 cases which needed longer time. So what did we do? First of all, we stopped the offending drug after consulting her oncologist. She was giving non-steroidal eye drops 3 times a day and systemic acetazolamide 500 milligram, 1 tablet twice daily for 4 weeks. After 4 weeks, best corrected vision improved in the right eye to 0.7, back to normal, when the left eye 0.7, back to normal before her condition started. So let's remember the OCT macula that was done 4 weeks ago after starting her symptoms. And let's see the new OCT after 4 weeks showed complete resolution of the cystic spaces and the schisis, which completely resolved, leaving a dry maculae both eyes. This is the upper picture show the first OCT, and the lower shows the new OCT after 4 weeks. Okay, let's have a talk about paclitaxel in a few minutes. It's a prototype of taxane family of anti-tumor drug. Its effect comes from its microtubule stabilizing effect, which lead to mitotic arrest. It has been approved by the FDA for treatment of many cancers, including breast cancer. It is known to produce multiple ocular side effects that may include visual impairment, photopsia, and ischemic optic neuropathy. Fluorescein non-leaking cystoid macular edema is thought to be due to dysfunction of Muller cells leading to fluid accumulation, and its toxic effect on microtubules leading to RPE dysfunction rather than vascular leakage. Okay, what is our take-home message? Good history taking is always a clue to reach your diagnosis. Good interpretation of the investigations done may also give a clue. And please don't rush into intravitreal injections. Before knowing the etiology of the disease, it may go away on its own. Thank you.
Thank you, Fadi, and I'm sure Dr. Hani will not leave you without some few questions, because he's the most popular ocular oncologist in the Middle East.
Thank you,
Fatih. He will forward you some questions. And by then, I hope that Dr. Ala will be ready with his presentation. Dr. Hani, please go ahead.
Actually, very interesting case, Fadi, and you highlighted several points about the history that you introduced nicely in the presentation at the beginning as one of the information that she has a metastatic breast cancer. I would like you to highlight the point. How did you get to the diagnosis that this is a toxic macular edema rather than a leakage? Because this is a very important point. Why did you suspect that this is the drug, not any other thing?
Because there was no anything. She was not. She's not diabetic. She don't have any signs of vein occlusions or uveitis or anything. And also the fluorescein showed no
yes.
leak at all.
You
Yes.
mentioned this in the presentation, and this is to be highlighted. It's a non-leaking macular edema. Although the picture on the OCT looks with the cystoid spaces, but you cannot find space. Similar picture can be found with prostaglandins sometimes that patients use. Also, it's drug-induced. Actually, a very interesting case, and I really find it really teaching and educational for many audiences to take a proper history from their patients. And it's good that you did not rush to other diagnoses and start injections, because I am sure that this patient would have been injected if she has presented to someone else without having this background. Thank you.
Thank you, Dr. Hani.
Any more questions, please? So we go ahead with the next presentation, Dr. Ala. And the title is Dig a Little Deeper.
All right. Good evening, ladies and gentlemen. Thank you for joining us tonight. So our patient is a 29-year-old athlete, male patient, presenting with a 6-month history of abnormal vision in the right eye. He described it as a grayish central hue. He was not diabetic or hypertensive with no history of medication. So this is a backstory in his own words, and this is important for our diagnosis. So the patient gave a history of a knee surgery that was done 6 months ago. He said he woke up in the ICU 3 days later. He said the nurse found him unconscious in his bed the day after surgery, and then he was told that he suffered a lung embolism. His orthopedic surgeon referred him to 2 ophthalmologists who told him that he had 6/6 vision and both his eyes were fine. The orthopedic surgeon accused him of malingering his symptoms to ask for liability compensation, and then his ophthalmologist referred him for imaging of basically everything. So he wanted a little more precise opinion. So this is an examination of the patient. Visual acuity was 6/6 in both eyes. Everything anterior segment-wise was completely unremarkable. This is the fundus photo of the right eye, the one that he was symptomatizing with. As you can see, the vitreous is clear, the disc looks fine, the vessels are okay, the macula looks pretty okay, and then this is the left eye, also looks completely unremarkable. So further clinical evaluation, the Ishihara charts showed intact color vision. However, when I gave him an Amstar grid, he did identify a fine positive scotoma using that right eye. So how to proceed? At this point, you either have the option of just assuming that the patient is definitely malingering, asking for liability compensation. You can just send him for a neurological consultation, or you could just review the history and try to connect the dots. So the things that struck me in his history is that he had a knee surgery, which is a major surgery, a long surgery, and then he suffered a pulmonary embolism after the surgery. So it seems like something vascular is happening, in which case it's important to review the retinal capillary blood supply. So as we know that the retina is supplied by 3 plexuses, the superficial, intermediate, and deep plexuses. And at the moment, optical coherence tomography angiography, or OCTA, is the only in vivo method of identifying these plexuses and studying them in patients. And so at this point, I decided to do a retinal vascular and structural assessment. I did a fluorescein angiography and an OCTA. So as expected, because the fundus looked okay, the early frames were normal, the periphery was fine. The late frames did not show any non-perfusion or leakage in the macular area. However, if you look at the OCT of this right symptomatizing eye, you can clearly see that the outer plexiform layer is showing these areas of irregularities and punching out. Whereas if you look at the left eye, it looks completely normal. And this is a side-by-side examination of the right eye and the left eye. Clearly, the photoreceptors are okay, which is why his vision is 6.6. And in order to understand what's happening on the capillary plexus, I decided just to review the anatomy. This is the outer plexiform layer. So basically, this is supplied by the deep capillary plexus. So this is where I expected to find the pathology happening. And obviously, again, as I said, the OCTA is the way to go. So this is 6x6 examination of the right eye. Show this larger FAZ in comparison to the left eye. You can clearly appreciate the capillary dropouts on the en face OCT image in the right as opposed to the left. And then this is a magnified image comparing the right FAZ and the left FAZ. And then again, a more detailed image of the FAZ in a 3x3 millimeter slab. Again, a larger irregular FAZ in the right eye compared to the left, and then you can see it in the en face. And obviously, the magnified image tells you the whole story. There's a much larger irregular FAZ with capillary dropouts corresponding to the areas of non-perfusion that we saw in the OCT. So basically, the diagnosis at this point is technically it's an outer plexiform disruption secondary to deep capillary plexus insufficiency, or what we call a long-standing acute macular neuroretinopathy. So contrary to popular belief, AMN is actually a very old diagnosis. It's been described by Boss in 1975 in a case series of middle-aged women presenting with abnormal scotomata, where he identified these abnormal images seen in the fundus photo. Up until the late 1990s, all we knew about patients presenting with acute postoperative vision was those that presented with much profound visual loss, which was caused by ischemic optic neuropathy, retinal artery occlusions, cortical blindness, or venous obstruction. But obviously, because of all the advances in multimodal imaging in this era, we can identify much more in detail what's happening in AMN. You can see these lesions in the autofluorescence, showing hypoautofluorescence, and you can see them in the en face, and then you can see them in the OCT-B scan as these hyperreflective structures occupying the outer plexiform layer and the outer nuclear layer, and obviously the photoreceptors. And then the long-standing cases show these atrophic areas where you can see them in the outer plexiform layer, corresponding to the ones we saw in our patient. This is actually not a new diagnosis. There are multiple case reports showing AMN in patients presenting with multiple weird diagnoses, such as in this patient, which received a trauma to the chest and presented by AMN. This patient was a pregnant patient and developed hypovolemic shock and then developed AMN. And then this patient developed AMN after a nasal surgery. This is not to be confused with PAM, which is basically the cousin of AMM, where you can see the similar pictures on the en face and the autofluorescence and the spectral light ophthalmoscopy. However, the hyperreflective layers are definitely affected in the middle layers as opposed to the outer layers. So this is a side-by-side. AMN affects the outer plexiform, outer nuclear and photoreceptor layers, whereas PAM affects the inner plexiform, inner nuclear, and sometimes the ganglion cell layer. It's important to understand the capillary pathology of both diseases. OCTA was able to demonstrate that AMN is associated with deep capillary plexus affection, whereas PAM is affected primarily in the middle and the deep, as well as the superficial, which explains why different layers are affected in the diseases. Long-term sequelae of AMN, many patients completely resolve, as you can see in this patient right here on the left-hand side, where most of the scotomata can be completely gone. However, in many of the patients, the outer plexiform layer, the nuclear layer, and the photoreceptor layer usually passes into these atrophic changes, and the scotomata might not improve over time. And so basically the take-home messages from this patient is, we're not internists, but history taking is definitely priceless. You have to keep an open eye to the patient's complaints. There's definitely more to vision than visual acuity. 6.6 isn't always normal. AMN and PAM are vascular insults on a capillary plexus level, so you have to consider these in high-risk cardiovascular patients, as well as in post-operative patients presenting with stomata. Multidisciplinary imaging is key. You have to ask for the right ones in your patients. Your patient will appreciate the information and the visual documentation of what's going on, even if you don't have a cure for his symptoms. And there's always more than what meets the eye. You just have to dig a little deeper to find it. Thank you very much.
Thank you, Ale. And again, for questions from the judges. And I hope Dr. Nagwa is ready with her presentation.
Ale, in your opinion, what has caused acute macular neuroretinopathy in this patient? I mean, there are several causes of this disease, but in this particular case, what was the inciting factor causing the insult to the retina? What was the final prognosis for vision in this patient? And if you have instituted any treatment for him?
We definitely know that this is a vascular insufficiency. So it's either caused by embolic origin. So basically, maybe there were showers from the pulmonary embolism that might have trickled over to the retinal capillary plexus. It might just be that severe hypoperfusion happened after surgery, and the hypoperfusion led to some sort of vascular ischemia. So this would be the pathogenesis of why there are capillary dropouts. In terms of the prognosis, this patient actually presented 6 months after the initial surgery. So this is 6 months into what happened, and the patient did not improve. He still sees the stomata. So it doesn't look like the patient is going to improve a lot, especially given that we can already see that there are atrophic changes on the outer plexiform layer. And unfortunately, I did not give him any medication because, again, this is not something that we can treat. I just told him that he needs to continue following up with a cardiologist just to make sure that this was a one-time event that happened because of the cardiovascular insult and not something that underlying pathology is happening.
Just one thing, that this was not probably an embolic insult, because, I mean, it would not select the perifoveal capillaries and target them. Probably the profound systemic hypotension caused by the pulmonary embolism that caused this. Thank you, Ale.
Thank you, sir.
Just to add to the point of Dr. Hamza, when you have a knee surgery or hip joint surgery, there is a moment of sort of anaphylactic shock when they use glue for the artificial joint. So this is a stress for all the organism, and probably this might be the cause also. This anaphylactic reaction, which is hyperthermic. The anesthesiologists know that.
Thank you, Dr.
My comment.
Presentation.
Dr. Trace, please introduce the next speaker.
The next speaker is going to be Dr. Nagwa Slimane, and she's going to discuss multiple vascular abnormalities.
Good evening, everyone. Our case today about 50-year-old female was complaining of the diminution of vision for 5 months in her right eye. She received multiple intravitreal injection of anti-VEGF. Her visual acuity is 0.5 in the right eye and 1 in the left eye. We ordered her OCT angio will show premacular anastomosis between abnormal vessel crossing the horizontal raphe and the superior temporal artery, and 2 areas of tangled morphology of vascular network at a level of choroid in premacular area and prepapillary area. The OCT show breaking in proximal membrane and RPE complex with arising new vascular membrane, like this. The multi-color photo show body-round appearance and justifoveal CMV in the right eye and 2 abnormal retinal vessels, one crossing the horizontal raphe in premacular area and anastomosis between the superior and inferior temporal artery. Autofluorescence show hypofluorescent radiating band rising from optic disc, and multiple hyper-autofluorescence corresponding to drusen-like deposits as seen in the OCT. Fluorescein of the right eye show filling inferior temporal artery with abnormal retinal vessels. The direction of blood flow from the inferior to superior temporal artery with hyperfluorescence of angiota streak and late leakage of active CMV. Left eye show combination between hyperfluorescence and blocked fluorescence of RPE modeling. Diagnosis is android streak with multiple retinal vascular abnormality and active juxtafoveal CNV in the right eye. Is there any correlation between android streak and retinal vascular abnormalities? This article shows retinal vascular abnormality associated with android streak and pseudoxanthoma elasticum, like papillary vascular looping, post-lamellar division of central retinal artery, which may cross the horizontal raphe, and abnormal arteriovenous communication and multiple branching. This photo from the article show retinal arterial anastomosis and abnormal location of vessel which crossing the horizontal raphe, like my case, and papillary vascular loop. Android streak is dehiscence and breaks in elastic lamina of Roch's membrane, appear like radiating lines from the peripapillary area. Most of cases are asymptomatic unless the CNV is developed. 50% of android streak are idiopathic, but some association like pseudoxanthoma elasticum, Badger disease, and sickle cell may be associated. So we return back to our patient and asking for and looking for skin manifestation and GIT manifestation for pseudoxanthoma elasticum, which is a hereditary disease and more prevalent in the women, affect elastic tissue of the skin, eye, and blood vessels. With clinical manifestation like small yellow papule plaques appear in flexure area, neck and neck and axilla. Vascular manifestation, intermittent claudications, and GIT hemorrhage, cerebrovascular abnormality, intracranial arteriovenous malformation, and TIA. Other vascular manifestation, chororetinal vascular abnormality, intracranial arteriovenous malformation, and orbital varices. So home massage is chororetinal vascular abnormality may be associated with android streak. So MRI and MRA is recommended in android streak with abnormal vascular, and skin biopsy for diagnosis of pseudoxanthoma elasticum with degeneration and fragmentation of plastic fiber in mid-dermis with positive stain for calcium. Thank you.
Thank you, Nagwa, for your presentation. And now please receive some questions from the judges. And I hope Lydia Magid will be ready again. Please go ahead, sirs, if you have questions for Nagwa.
Nagwa, how did you manage this case, and how would you expect the prognosis following injection in such cases?
Here she continued the injection for the active CNV, and the prognosis is very poor, as is most of cases ended by scar, chororetinal scar.
Yes, the recurrence rate, these are very active membranes actually, and although they respond initially to anti-VEGFs, but with time they become more resistant and scarring. And did you do the skin biopsy for this patient?
Unfortunately not. She disappeared.
Not.
Yes.
So you didn't continue the rest of the investigations. I mean, okay, thank you.
Any more questions for the candidate? Thank you, judges. I'm waiting for your scores. And now we have Lydia Magid again, and her presentation this time is lumpy, bumpy macula. Please, Lydia, go ahead.
Hello again, the lumpy, bumpy macula. A 16-year-old girl presents to clinic with poor vision in her right eye, which she discovered 2 weeks earlier. Her vision in that eye was 0.05, and fundus examination revealed a yellowish lesion with central intra and subretinal hemorrhage. And this is the color fundus photo of her lesion. It is a hypoautofluorescent lesion with gravitational sign, and on fluorescein angiography, there is early hyperfluorescence with late staining and a lacy filling pattern centrally consistent with CNV. On OCT, we see a spongy swelling with a spongy lesion with a lamellated appearance, and on enhanced depth imaging, there is a prominent sclerochoroidal junction, as can be seen here. OCTA further highlights the CNV, and on ultrasound, this lesion is hyperacoustic with a dense shadow. It is right next to the optic nerve head, It has very high echoes and a very dense shadow. So what is this lesion? She was diagnosed as a choroidal osteoma, complicated by CNV, and she was prescribed intravitreal anti-VEGF and followed up. How do we diagnose a choroidal osteoma? First of all, by history. It most commonly occurs in females in their late teens or early 20s. It may be asymptomatic or may present by visual symptoms when it is complicated, such as in this case. The clinical signs are an irregular elevated yellowish-white lesion that is close to the optic nerve head, and it has well-defined geographic borders. It has a diffuse and mottled depigmentation of the overlying RPE with multiple small vascular networks on the surface. Using investigations, ultrasound shows the pseudo-optic nerve head sign, which we mentioned earlier, the dense shadow. It is usually hypo-autofluorescent unless it is complicated by RPE atrophy or decalcification, in which case it will show patchy hyper-autofluorescence. And in fluorescein angiography, it shows early hyperfluorescence in the choroidal phase with late staining and CNV if it is available. Enhanced depth imaging shows a spongy lamellated lesion with prominent sclerochoroidal junction, and OCTA further highlights the CNV. The management of such a case is to just follow up for complications. The complications that can occur are CNV, which is treated by intravitreal anti-VEGF, and decalcification, which is a condition where the lesion loses its calcific deposits, and this leads to arrest of its growth and could also lead to involution, but it results in RPE and photoreceptor atrophy and may compromise the visual outcome. The differential of such a case includes an amelanotic melanoma, which occurs in older age in both genders. It is usually more brownish with poorly defined edges and a smooth surface, large sinusoidal vessels on the surface as opposed to small vascular tufts, and a juxtapapillary location. On OCT, it shows shaggy photoreceptors and subretinal fluid, and it is usually hyper-autofluorescent due to lipofuscin deposition, which is usually a sign of malignancy. On ultrasound, melanoma is characteristically hollow or hypoacoustic. The amelanotic nevus occurs in both genders. It has less defined margins and overlying drusen. OCT shows compression of the choriocapillaris with choroidal shadowing, a gentle contour, photoreceptor layer loss, and occasionally PED. It is hypo-autofluorescent, as most benign tumors are, and it is dense on ultrasound. Choroidal metastases are bilateral with indistinct margins. They have no vascular tufts on their surface, and OCT appears lumpy-bumpy, sometimes associated with subretinal fluid. Also, sclerochoroidal calcification, which is calcific deposits that occur in patients with hypercalcemia. They may be peripheral and multiple and may be bilateral, and they usually have the labs and history suggestive of the medical cause, which may be hyperparathyroidism or renal failure or any cause of hypercalcemia. Lymphomas occur in the 4th to 6th decade. They are usually accompanied by anterior or posterior uveitis symptoms and signs. They have leopard skin pigmentation and may be multiple. On OCT, they appear undulating and have associated subretinal fluid. They are hyper-autofluorescent, and hemangioma occurs in both genders. It is sessile, smooth, and solitary. On OCT, it appears dome-shaped, may be associated with subretinal fluid or CME, and it has a higher internal reflectivity on ultrasound, and it is hyperfluorescent on fluorescein angiography. To recap, choroidal osteoma is a benign ossifying tumor that occurs in young females. Its characteristic features are a yellowish-white color with well-defined geographic borders. It is close to the optic nerve head, and on fluorescein angiography, it has early filling and late staining. On enhanced depth imaging OCT, it is spongy with lamellated appearance and a prominent sclerochoroidal junction. It is hyperacoustic with a dense shadow, and it may be complicated by CNV or the decalcification. Thank you.
Thank you, Lydia, for your second presentation. Please ready to answer one or two questions from Georgia.
Thank you, Lydia. This is a very interesting case indeed. And I would like to ask you, what about if you would like to do another investigation, a non-ocular investigation that would reveal the diagnosis? What do you think it would be?
I would
A
think
very simple investigation.
X-ray.
Plain X-ray or CT scan. It will reveal calcification at the level of the choroid and is usually diagnostic in these cases. Did you do any systemic workup for this case, or you went directly to the diagnosis of osteoma? I mean, you did check the serum calcium, the parathyroid level, any other investigation?
Well, the OCT was characteristic mostly, so no systemic.
So you didn't do any other systemic investigation. And you treated the patient. How did you treat the patient?
She was given anti-VEGF, but then she was lost to follow-up and didn't come back for her follow-up OCT.
Yes. Well, probably they end by scarring, but the calcification remains stationary throughout life, usually. Thank you, Lydia. Very interesting case indeed.
Thank you.
Just one suggestion, not a question. In the differential diagnosis, due to the hemorrhage and the hyperreflective dots on the OCT, plus the shallow NSD, one can investigate also a toxoplasmosis as a differential diagnosis.
Okay. Thank you. Thank you for the interesting comments. Thank you. Thank you, professors.
And he is going to
Dr. Tres, please introduce the penultimate talk.
Dr. Fadi Wahid is going to present 2 months apart.
Good evening again. Our next presentation will be is called Few Months Apart. Our patient is a 16 years old male patient presented with a rapid onset diminution of vision in the right eye and visual field defect. He has relevant past medical, ocular, and family histories. Ophthalmological examination revealed the vision in the right eye was 0.3, while in the left eye was 1. He was immetrope. The pupil shows a relative afferent pupil defect grade 2 in the right eye, while the posterior segment shows a slightly blurred optic disc margin with adjacent RPE changes. As we can see, this is his fundus photo showing a slight blurring in the optic disc with some RPE changes. Okay, he was diagnosed elsewhere as optic neuritis and was given intramuscular dexamethasone. This is his fundus fluorescein angiography. And we asked for a field. The field showed an altitudinal field defect in the right eye, while the left eye was completely normal. So we ordered MRI, brain, and orbits, and here was something surprising that showed a brain stem, a tectal glioma. Okay, what is a tectal plate glioma? It is a low-grade, slow-growing, benign brainstem tumor. It may cause hydrocephalic changes and pressure symptoms. Tectal glioma usually develop between the ages of 3 and 16, and it has good prognosis. It may be treated by VP shunt, chemotherapy, or systemic steroid to decrease the intracranial tension. Many cases with tectal glioma were reported to have neurofibromatosis by the time of diagnosis or during the course of the disease. Okay, the patient was referred to a neurosurgeon, but unfortunately the patient disappeared. But he came back after 6 months. He was complaining of the same visual field effect, but surprisingly his vision improved to 0.9, but he's still complaining from his vision in the right eye. The surprise actually was his fundus pictures. This is the first fundus picture that presented to us 6 months ago, and this is the new fundus picture, showing a pigmented lesion at the same site of the blurring of the disc margin. Okay, so we have, and this is the left eye is completely normal, while the lesion is only in the right eye. Okay, so we have a pigmented lesion at optic nerve head. Let's think about differentials. First of all, we should think about the melanocytoma of optic nerve head. Other differentials should be considered, like choroidal melanoma, choroidal nevus, hyperplasia of RPE, combined hamartoma of retina and RPE, adenoma of RPE, metastatic melanoma to optic disc. This is the OCT for this lesion. It doesn't show much elevation, as we can consider it as a very naive tumor that's only a few months old, as it wasn't present 6 months ago. It's only a few months of age. So it may be considered a melanocytoma of optic nerve head, which is a rare benign tumor that occurs in the optic disc and often extends in the peripapillary retina, and choroid. Most melanocytoma cause visual field defects ranging from an enlarged blind spot to nerve fiber bundle defects that result from compression at the optic disc. Mild visual loss can be due to retinal exudation involving the macula. Severe vision loss is rare but can occur secondary to central retinal vein occlusion, spontaneous tumor necrosis, or even malignant transformation. At the time of diagnosis, fundus photo should be taken and visual field testing should be performed. The patient should be followed annually. In addition, OCT can be used both to document the extent of the lesion at diagnosis and to track any progression. Vision loss accompanied by significant growth of the tumor must raise concerns for malignant transformation, and inoculation may be considered. However, if the vision loss is a result of ischemic necrosis, the recovery of some vision may be possible with observation alone. It is usually an isolated disease, but some studies suggest that it may be associated with neurofibromatosis. So in this patient, we have two lesions, melanocytoma and tactile glioma. So is there any association between them? Actually, yes. Both tumors are neuroectodermal in origin. Each one of them can arise as an isolated disease, but they may also arise together as a part of neurofibromatosis, as reported in very few cases worldwide. Okay, to summarize our take-home message, melanocytoma of optic nerve head is a rare benign tumor. It may occur as an isolated disease or in association with other CNS disease. It needs close follow-up to track any progression and any other associations that may appear later. Thank you.
Thank you, Fadi, again, and please wait for one or two questions from the judges.
Fadi, how would you differentiate the melanocytoma from a juxtapapillary melanoma?
Okay, actually, I maybe by the OCT, I don't know.
I mean, first of all, the color. The melanocytoma is usually jet black. The melanoma is grayish or dirty gray in color. Second, the presence of exudative retinal detachment, which is usually associated with the melanoma, while the melanocytoma is usually white. But what I wonder is that you saw a melanocytoma developing in this patient, I mean, over a few months, which is quite rare. I mean, it has never been reported that you see a patient and after a few months, he develops a melanocytoma. So it's quite interesting case and well documented as well. Thank you.
Thank you, Dr. Hain.
Any more questions to Dr. Fadi? So this takes us to the ultimate presentation by Dr. Hams, this orbital angioma. Please, Hamsami, go ahead.
Good evening, everybody. Orbital enigma. An 84-year-old male patient came presented to us at the hospital's clinic complaining of head trauma 20 days ago. He was complaining of progressive protrusion and redness of the left eye. He says there was a history of hepatic impairment and nephrectomy and cataract surgery in both eyes 20 years ago. His best corrected visual acuity was 0.2 in the right eye and 0.05 in the left. IOP was 17 in the right, but couldn't be obtained in the left. Anterior segment examination showed conjunctival injection and chemosis in the left with dilated conjunctival vessels and pseudophakia in both eyes. Posterior segment examination showed an AMD in the right eye, but couldn't be obtained in the left eye. He had restricted motility in all gazes in the left eye. Lesion adnexia examination showed entropion and wrapping lashes in the right eye. Left eye showed proptosis, lid edema, and ptosis. This is a picture of the left eye of the patient. What would be a differential diagnosis for such a case? a thyroid eye disease, orbital cellulitis, orbital pseudotumor, superior orbital fissure syndrome, orbital apex or carotid cavernous fistula. Quick review of these different entities for the affected structures of these diseases. For the superior orbital fissure syndrome or the orbital apex, all the contents of the superior orbital fissure could be affected. For the cavernous sinus syndrome or the carotid cavernous fistula, the structures of the cavernous sinus can be affected. But for the retrobulbar hematoma, any of the contents of the orbital cavity could be affected. There's a very diagnostic sign for the carotid cavernous fistula, which is the orbital berry. For the management of these cases, CT, brain, and orbit would be of high importance for all cases, but for the carotid cavernous fistula being vascular disease, a cerebral angio would be of utmost importance. Quick review of the anatomy of this area. The cavernous sinuses are a paired structure lies on both sides of the pituitary gland, containing a venous low pressure plug in which a high arterial plug of the internal carotid lies within the sinus itself. There are cranial nerves on the lateral side of the cavernous sinus, and also the abducent lies adjacent to the internal carotid artery. What's a carotid cavernous fistula? It's an abnormal shunt between the internal carotid artery and the cavernous sinus. It can be classified according to the etiology, traumatic or spontaneous, according to the velocity, high versus low flow, for the anatomy, direct versus indirect. This is a classification done by Preoperative, classifying the fistula into 4 types. The first type is type A. It's a direct shunt, and it's the only high flow shunt directly between the internal carotid artery and the cavernous sinus. For the 3 other types, they are indirect shunts of low flow between the internal carotid and the cavernous, or between the external carotid or the cavernous, or between both the internal carotid artery and the cavernous sinuses. What would we ask about for such a case? History. We should ask about trauma, recent childbirth, surgical intervention, atherosclerosis, hypertension, collagen vascular disease, or even connective tissue diseases. Symptoms would be a diplopia, red eye, headache, vision loss, or bereaved, described by the patient as swishing or buzzing sound. Clinical manifestation would be a proptosis, conjunctival chemosis, arterialization of conjunctival vessels appearing as dilated tortuous vessels looking like a corkscrew, eyelid edema, or ophthalmoplegia. Complication might be exposure keratopathy due to the proptosis, vitreous hemorrhage, or optic nerve compression, and ocular manifestation to contralateral side. This is a case report from cardio.com showing a unilateral direct cavernous fistula causing bilateral ocular manifestations. This is due to the intercommunication between 2 cavernous sinuses by the intercavernous sinuses, which lies anterior and posterior to the pituitary gland. Management would be a cerebral angio CT MRI. This MRI shows a dilated cavernous sinus, and in letter B, a dilated superior ophthalmic vein with a Doppler showing the dilated cavernous sinus. Management, which such a case for us as ophthalmologists, for the exposure keratopathy, we should prescribe ocular lubricants, tarsorrhaphy in severe cases. For the glaucoma, equisuppressants or hyperosmotic agents. But above all, we have to refer this patient to an interventional radiologist, because this patient might lose vision in both eyes, where they do a coil to close the fistula between the artery and the vein. So to wrap it up, a thorough history taking and always searching for the signs. For this case, a corkscrew vessels and orbital berry can be your clue to diagnose a carotid cavernous fistula. Thank you.
Thank you, ma'am, for your presentation. And now please receive 1 or 2 questions from the judges, then we'll be all finished.
Hams, was there a pulsating exophthalmos in this case?
Actually, this patient was very irritable. He was complaining of like a berry or swishing sound, but I couldn't touch him. Actually, I took these pictures very hard.
And you didn't see, I mean, this is just by inspection to see that the globe is pulsating forward and back. And what was the fundus picture? I mean, did you see dilated retinal vessels?
No, actually, I couldn't. The patient couldn't sit on the slit lamp. It hardly, we saw the anterior segment hardly, very hardly. We couldn't see the segment.
You can do it with the indirect ophthalmoscope even. That's anyway, it's an interesting case. That's an interesting case. Thank you for presenting it.
Thank you, sir.
Dr. Ala, Dr. Mishif, any further questions to any of the candidates? Okay, we have few questions from the audience, so I wonder if we have just a few minutes to answer some of them. There's a question to Peter, who presented the femto-iris. What will be the situation if you need to treat the retina for any future insults? Is Peter here?
I'm sorry, Dr. Fatih, what is the question again?
The question asking, now you have pigmented cornea that might be obscuring the fundus view. What if the patient develops retinal detachment, for example, and he needs vitreoretinal surgery? What would you think that the situation would be?
Can I answer for Peter?
Please go ahead.
I'm sorry, I can't hear this. There is a technical problem. Can I wait, please, Dr. Fatih?
Now we have a small pupil after you pigmented the cornea, and the question is, what if we need to do vitreoretinal surgery?
I think even with this pupil that is about 4 millimeters, you can do, using the newer visualization systems, the vitreoretinal surgery in these cases with indentation. He did not make a very small pupil. He left 3.5 to 4 millimeters pupil, I assume, Peter.
Yeah, that's exactly.
Dr. Fatih, please, I'm sorry.
Yeah, we have
Can
been
you
helped.
repeat the question, please?
We were asking about the pupil, when the pupil is small after keratopigmentation. Assessment of the fundus and having to have vitreoretinal surgery might be difficult. This was the question.
Yes, actually, we did a trial for fundus examination. Okay, she is a very young child. We did it intraoperatively under general anesthesia. When we are removing the stitches, it was a very good view and a good field also. And if there is anything, we can wash the pigment away. If there is anything needs to be, the fundus to be examined to the periphery, we can wash this pigment away. But it's very good field. We tried it.
Now there's another question for Lydia Magid. Lydia, are you here?
Can I comment again on the femto-iris? Because I asked the question and it seems to not be understood. In congenital aniridia, there is a limbal cell deficiency, and they tend to develop keratopathy with vascular component over the epithelium. So this tattooing of the cornea, is it the smartest move or the right thing to do on congenital aniridia? How the pigment relates to the limbal cell deficiency?
Peter, are you here to answer?
Yes, I'm here.
Did you hear the question?
Again, please.
The question is, do you know that in congenital aniridia, there is a limbal cell deficiency? And this condition tends to promote vascular membranes over the epithelium of the cornea, called keratopathy. How that relates to your pigment in the stroma and to your manipulation over the cornea, because this is the major issue in the congenital aniridia, no matter it is Gillespie syndrome or Wager, etc.
Okay, in literature review, okay, a medium and long-term follow-ups is done on a patient with congenital aniridia with a mean around 29 months Some of them was around 69 months, and there was no any complications. Okay, and every complication was adequately managed, and satisfaction of the patient was about 95% at their values. In the last paper I published, I presented here. It was on July 2020. Okay, I can send to you, sir, after the presentation.
Okay, thank you.
Thank you.
Thank you, everybody. And now I have the results ready. Now we have 4 awards. The first one will be given to the doctor who actually participated the most during the grand round, and it was Dr. Noha Fawqi, one of the 11 presenters today, that she's a committed person. Noha, can you show yourself, please?
Thank you so much. Thank you.
This is Noha Fawqi, that the doctor has participated most to the grand round, and we thank you, Noha, and we're giving you a symbolic gift of 4 Egyptian £1,000 in relation to your effort in the grand round. Thank you, Noha.
Thank you.
You want to say a word?
Here, and thank you for giving me.
Can you ignore the music a bit? If you say a word in half a minute.
Yeah, okay, I'll repeat it. I'm very thankful for being here, and thank you for the opportunity. It means a lot, so thank you.
Thank you, Noha.
Thank you.
Now, before I announce the result, I want to say a few words that actually the differences between the candidates, between the very first one and very last one, is a small difference. And the differences between the assessment of the judges is really very, very minimal, which would say that the assessment is very fair for all the candidates that have participated. And I will start with the 3rd place. And the title of the 3rd place is the Lumpy Pumpy Macula, presented by Lydia Magid. Lydia, can you show yourself, please?
Thank you very much.
Congratulations,
I'm
Lydia.
glad you liked it.
And I give you half a minute to say a word.
Thanks for the opportunity, and I'm glad you liked the presentation. Glad that you were with us today. Thank you very much.
Thank you, Lydia. And the award is again symbolic of 4,000 Egyptian pounds. And we go to the 2nd place, and the title of the 2nd place is A Clue for One of a Few, presented by Fadi Wahid. And please, Fadi, present yourself and show yourself. Now we can have the music, please, until Fadi starts to talk.
Thank you, Dr. Fathi. Thanks for the jury. I'm very proud for being here, and I wish to be here again. Thank you.
Thank you, Fadi. And again, a symbolic reward of 6,000 Egyptian pounds. And now we come to the 1st place, and he's actually a very recurring winner at Watany Eye Hospital, and a very clever man, proud of him. And the title was Dig a Little Deeper, presented by Ala Fayed. Ala, can you show yourself?
Thank you, Dr. Fathi, and thank you to all the panelists. I appreciate your support. Thank you very much.
Very well done, Ala. And now I'm sure you can buy a new car. You have
yes, I definitely need a new one. Yeah.
10,000 Egyptian pounds. I'm sure for all the rewards you have collected at different contests, you can be a rich man. And
thank you very much. I appreciate it. Thank you, sir. Thank you.
And now I want to hear a last word from each of the judges. Please, Dr. Ala.
Really, it was a pleasure to join you today in your meeting. Actually, it was also a pleasure to see all these competitions, and really the judges, I believe, they were very homogeneous in their judgments.
That's true.
And congratulations for the winners. Thank you very much.
Thank you very much, Fathi, for being part of this event. Actually, I would like to congratulate all the participants for their presentations. As you said, the differences were very minor between them, and it was a very tough decision to take one and prefer a presentation over the other. And I was very also happy to see many cases about oncology and intraocular tumors. So this was quite interesting for me, and I enjoyed the evening. Thank you, and hope to see you again in the future.
Thank you, Hani. And our international guest speaker, can you have a last word from you, please? Luca.
It was a really exciting contest, and all the participants and the level of the comprehension and the information and cases were really interesting. I enjoyed being here as a judge, and I thank you, and I'm honored to be here. Thanks.
Thank you, Loken, and I want to have few words of thanks. First, I would thank Dr. Therese Kamel. Really, she is the backbone of this meeting, and she is the heart that's pumping life into this meeting. She keeps nagging everybody to work and get their presentation ready, including myself. And I thank her for keeping this activity live. It's an effort. I know she's very busy with the uveitis, with the OCT and the fluorescein angiography and her publishing work, but now she's giving good time to this meeting. And this will approach us to the conclusion of the meeting of this session. And I just want to say that tomorrow is going to be the glaucoma meeting. Thursday is a cataract and refractive surgery meeting. It's going to be very interesting. And on Friday, we have the live surgery transmitted online. And I want to thank everybody that has participated in this virtual meeting. Hope next year we'll be meeting face-to-face. And I would thank all the consultants that put in time. And the last word, that the achievements do not come by itself. There are people who are working behind the scene and giving great effort and putting everything together. So I must thank Dr. Nader Fauzi and Dr. Bahrawi for putting all things together to have a successful meeting. Thank you, everybody, and thank our judges. It was a great honor to have you all with us, and have a very good night, and congratulations, all the winners.
Thank you. Thank you, Dr. Fathi. Thank you very much.
Oh.
Bye-bye.
Bye-bye.
All the best.